Hi everybody, can we hear okay? I can hear me very loud, so if it's too loud we can adjust it. I'm going to hand the mic over to our wonderful MLA Aleana Young, who's going to host our evening, our town hall. Thanks so much for coming out.
Well, yeah, everybody, great to see you. Thank you so much for coming out. Pleased to be here on a beautiful, potentially spring-like evening, Treaty 4 territory, homeland of the Métis. Before we kick things off, I want to start, first of all, by thanking all of you for being out. And second of all, for thanking the person who has made all of this happen, and that is the absolutely stupendous Jocelyn at the back, who's coordinated all of this, booked the room, set up the chairs, got cookies, got our wonderful panelists out here, and has facilitated this evening of, I think, really, hopefully really good discourse and learning. So Jocelyn, thank you so much. I could not get through the days without you, and I'm so thankful you're part of our team. Yeah, I'm Aleana. I'm the MLA for Regina University. Hopefully after the next election, I will be the MLA for Regina South Albert. Due to some of the boundary changes, I'm tragically losing University Park and picking up Albert Park, potentially if the good people of South Regina will have me back, which I hope they do, but who knows, we'll see. This evening is a town hall that we're doing on healthcare by popular request. At each of our town halls, we take a survey of people in attendance to see what they would like to talk about. So you do have feedback surveys through QR codes as well as here at the front. So please let us know what you would like us to facilitate next. These tend to be very comfortable, free-flowing discussions. We do our best to facilitate a group of panelists with expert and lived and real-world experience, with great ideas, with great stories and great personalities. But this is really about civil society, I think, at its best. Grassroots engagement, community feedback, ideas, questions, and discussions. So please take this as very friendly, very safe, very informal. Ask whatever questions you want. We do have microphones. We will endeavor to use them so everybody can hear. I will probably be the one struggling to remember that. So without any further ado, I'm going to introduce our three wonderful guests, and then we're going to kick it off with some discussion questions. But if you have a song in your heart, if the spirit moves you and you want to jump in, please just raise your hand. But beyond that, we'll ask everybody to respect the group. If you've asked 18 questions, please don't ask a 19th unless no one else wants to. You know, as always, be respectful and friendly and considerate of your neighbors. I have no doubt that is going to be the case. It's never been an issue, and I'm so thankful that you're here. So thank you so much. Our first, I feel like this is like The Bachelorette or something. Our first panelist is Dallas. I had the good fortune of meeting Dallas when I knocked on her door maybe 3 years ago, which was, I'm just so thankful for that interaction. But in 1988, Dallas and her family moved from PA to University Park in Regina. And when her youngest went to high school, you're the oldest. Oh my gosh, okay. Dallas began working in the health system, first in a personal care home and home care for 10 years, followed by a job in an emergency intake shelter for children that was being set up by the YWCA. Dallas retired from this job at 65 when her physical health began to become an issue. Her experience with the healthcare system took a turn, resulting in a very tough year and a half, with 2 hip replacements and the discovery of breast cancer requiring 5 months of chemotherapy, surgery, and 16 days of radiation. Dallas credits her recovery to the wonderful care that she received from her team of nurses, who she knows were working short and on overtime, and doctors, oncologists, surgeons, and internists. Since she completed radiation last year, Dallas has been participating in a cancer drug study, and so far, so good. In Dallas's words, I consider myself very lucky to have met a GP, who has since moved to Toronto, who sent me for an ultrasound followed by a CAT scan that found the breast tumors when a UTI didn't respond to antibiotics in a timely fashion. He saved my life, and I'm grateful to him, as I am to all the follow-up care that I'm receiving to this day. Dallas. Next up, we have Donna. I've always said your last name is Pasiechnik. Pasiechnik. Donna Pasiechnik, a tireless public health advocate who's worked as a journalist, professor of journalism, and public policy analyst with the Canadian Cancer Society, speaking on behalf of the Society for nearly 2 decades. During her career at the Canadian Cancer Society, her leadership, hard work, and determination led to changes in provincial legislation, municipal bylaws, and new policies to protect public health. She was responsible for the passage of many cancer control laws, including Saskatchewan's public smoking ban, Canada's first asbestos registry, and regulations to protect the youth from the dangers of indoor tanning. In 2022, Donna received the YWCA Women of Distinction Award for Social Action and Advocacy for her work at the Canadian Cancer Society. Donna is now a self-employed visual artist and furniture restorer, very cool, using her art to support mental health charities and vulnerable populations. Donna loves a challenge and wants to make a difference in her community in all the work that she does as an advocate, a change maker, or as an artist. And last but not least, we have Dr. Tom McIntosh, who brings expertise in public policy, public health, and healthcare, as well as intergovernmental relations as the Associate Dean, Research and Graduate, the U of R Faculty of Arts, and Professor in the Department of Politics and International Studies. Tom is also the co-director of the Saskatchewan Population Health and Evaluation Research Unit, or SPIRIT? SPIRIT, there we go, where he is part of the research teams for dementia supports in rural Saskatchewan, the current state of rural healthcare in Saskatchewan, and addressing the wider health impacts of COVID-19. Tom's research has been published extensively, and he's worked for local, provincial, and federal governments, as well as the director of the Health Network for the Canadian Policy Research Networks. Wow, I'm very interested.
It just means I can't keep a job.
So with that, I'm going to stop talking and sit down. Did anyone have any interest in giving some opening remarks, or should we jump right into the...
Oh, no, just
Jump right in, okay. Love this. Ruthless efficiency. So I guess maybe starting with the first question, which is a great one, I think, to kick off the discussion. And maybe we'll just go down the line, starting with Dallas. What led each of you to become involved in public health advocacy or policy work, as it were?
Well, I think meeting you over here. Can everybody hear me without the microphone?
No.
Okay.
It's on.
It is on. Okay, I think, well, I know, meeting Aleana at the front door a few years ago, and we spoke at length. It was a lovely evening, and I was leaning against the door because both hips were just garbage. And we talked, and her assistant Marshall got in touch with me a while later and asked if I would be interested or would agree to work with their health critic. At the time, it was the wait list for surgeries. I kind of thought, oh, okay. And then I didn't hear anything, and then the phone call came, Dallas, can you come to the ledge and be our guest for question period? And I said, okay, what do I have to do? And they said, well, if you're agreeable, would you answer some questions from the reporters afterwards? And I thought, all right. So I went, my daughter accompanied me, and I was in a wheelchair at that point because I couldn't walk very far. Because of the wheelchair, I ended up being fortunate enough to be on the ledge floor, parked by the doors. And there was question period, and there was questions asked, and on and on. And we were, both myself and Jesse were acknowledged by them, Ryan Riley, that we were there, I was there, to put a face on the people who were waiting for surgery. And I met briefly with Paul Merriman and then went outside to the reporters. But I was told I had a lot to say. And once you ask me a question, I just get on a roll, and so that went well. My daughter said it was just the best day of my whole life because she talked and everybody was listening. So I I like to think that at that time, we didn't, we were still stuck in COVID. And the surgery wait list was up to 25,000 waiting. But it would be another year and a half. And I knew where I was on the list with my surgeon. I thought, oh gosh, I'm gonna die in this chair. But anyway, as things turned out, things got moving along fairly quickly after Christmas, because this happened in November, and after Christmas I got a phone call that my surgery was booked, and I couldn't believe it. Anyway, fast forward, I had the 2 hips done, and in the meantime, through everything, I was diagnosed with breast cancer too, so I was just sort of reeling from one thing to another when I say it was a rough year. But having said that though too, I had wonderful care. Whatever drug they gave me to fight the nausea and other sickness with the chemotherapy worked wonders. I was not sick a day. I know people find that hard to believe because they had friends who really suffered. I did not. I was tired, but that was it. I got through it all, and I'm here today. And so I like to put my money where my mouth is, and if I have a chance to speak up and say anything to encourage or to make a noise about the way things are as far as the health care is going, I'm willing to do it if I can. If I know anything about it, I will. As far as, well, I guess we've got other questions going on, but anyway, that's me. If I can be a face or put a voice to a concern, I will. I'm more than happy to.
I'm willing to make a lot of noise too. So I have a background in journalism. I worked for the CBC for 12 years before I left the CBC, and then I taught journalism for a couple of years, and then stumbled across, what am I going to do? What am I going to do with my life? If I go get into communications or public relations, it has to be something that lines up with my values, because yeah, I can't spin stories. And so I came across a half-time job at the Canadian Cancer Society, and for a tobacco control advocate, and I thought, what is that? I used to smoke, maybe that that's experience enough. So anyway, I've always been a change maker. I've always been outspoken, and I'm a doer, and I don't believe in sitting around and complaining. I believe in sort of rolling up your sleeves and getting involved to get things done. I do not like complacency, I think, or apathy. I think we all have a role to play in society, and I think it's really important for voices to be heard. So for 17 years, that's what I did, and I loved the job, and I think my communications background and with the CBC really helped me. I was not intimidated by politicians because I interviewed them all the time, and that really was helpful to me, and I wasn't afraid to speak, and I think my media background really helped me to get our messages and out there. And so the pandemic came along, and there went my job. And but that was okay. That was okay. I was sort of growing tired of dealing with the current government that had been, in power for at that point, I guess, 15 years. Just a couple of years ago, I've been retired. But I'm still involved. So when the government was reluctant to adopt measures around the pandemic, I helped organize a rally and spoke out. My father is in long-term care. I'm an advocate for him, and have, on a number of occasions, had to sort of go to the top to get things changed and done for not only him, but for the other residents in his wonderful long-term care home. And yes, as Aleana said, I do art on the side, but I am still a bit of a political animal. And I just really care about our healthcare system, and I'm getting older, I'm 63, and I am worried about the state of care right now in Saskatchewan and where it's going to be when I need long-term care and I need more care, and I'm healthy now, so I can continue to fight for change and raise alarm bells and do what I need to do. And I think it's really important for all of us to use our voices in all kinds of ways. You don't have to be out there screaming, at the steps of the legislature. There's all kinds of ways to get involved. So I continue to be involved. That's what fuels me, and that's why I'm here. And I thank you for inviting me, and thank you for organizing this, Aleana and Jocelyn. It's awesome.
So my turn. It's not nearly as interesting, I don't think, as either of you. I laughed out loud when I saw the question, when I got the question. Because the short answer to how did you get involved in this is, in my case, entirely by accident. I literally fell into health policy. I had finished my PhD, I was working at Queen's University, unfortunately not in a academic position, but in a research position. I was underemployed. I had worked with a guy on a project through Queen's from Saskatchewan by the name of Dwayne Adams, who was the former Deputy Minister of Health, and also Deputy Minister of Social Services and various other things. Dwayne was leaving the government and opening up this little thing called the Saskatchewan Institute of Public Policy, and that would soon eventually morph into what is now the Johnson Shoyama Graduate School of Public Policy. And Dwayne phoned me up and said, I need somebody. You've got a PhD, you need a job. Come to Saskatchewan. And I'd never been to Saskatchewan. I'd flown over it a few times. I'm from BC. I was living in Ontario. So I knew it from 20,000 feet, but that was about it. But it was also a part-time job. And I said, Dwayne, I'm not moving to Regina for a part-time job. So Dwayne, if anybody here knew him, he was a bit of a fixer. He could fix things. And so he phoned me back about a week later and said, well, the other half of your job will be as a senior policy consultant in the policy and planning branch at Saskatchewan Health. Okay. I was trained as a political economist. I did labor market policy. My BA, or my MA and my doctoral dissertation were on the Canadian labor movement, which is just a perfect fit to be a senior policy consultant in Saskatchewan Health. So I came and I did it, and as it happened, a guy I knew was my boss at SaskHealth. And I said, I can spell Medicare, and that's about it, right? And he was very good. He looked at me and he goes, you have a PhD in a brain, C problem, apply brain. And it's that simple. And so that happened. I eventually left the government, worked full-time at SIP. There was another person who came to the Institute of Public Policy by the name of Greg Marshall, and this whole theme here is sort of the kindness of strangers. Greg had been the Deputy Minister to Roy Rona at Exec Council. What he was doing at SIP was actually acting as the liaison between Mr. Romano and Jean Chrétien to set up the Romano Healthcare Commission. And he was flying back and forth to Ottawa all the time. And the commission gets announced, everybody goes, that's really cool, Greg, I take it you'll be the executive director of the commission? Yeah, probably. And he walked into my office one day and he goes, you want to work on a royal commission? And I went, okay, why not? And I became the research coordinator for the Romano Commission. By that point, I was hooked. I was a healthcare guy. There was no turning back. And so when that ended, U of R approached me, and this is where Spiru comes into it, and offered me a position and said, we'll hire you into the political science department, but the there's actually no vacancy there, and there won't be for 5 years. So you'll spend the first 5 years with this new group we've set up called the Saskatchewan Population Health and Evaluation Research Unit, SPHERO. It's a horrible name. Nobody ever remembers it. People mix the E and the R anyway. And so for 23 years, I've been a member of the SPHERO research team. I did a decade as co-director of that unit. And it has been just an amazing sort of experience of doing community-based, publicly engaged research all across this province. A lot of my work in recent years has been rural places. We just did a report that QP was kind enough to pay for on the current state of healthcare in rural Saskatchewan, which is available on our website. Has some fascinating details about what's going on. And talking to healthcare workers who aren't doctors and nurses, because we only ever talk to doctors and nurses. And so in this report, we talked to only a couple of doctors and a few nurses and a whole lot of care aides and LPNs and other people who never get heard from again. The other thing that Aleana mentioned, and this is, I think, important for me too. We've been doing for the last 3 years a project called on supports for people in rural Saskatchewan living with dementia and their care partners. We got $3 million from the federal government to go into the Yorkton and surrounding area and have community-based organizations design interventions to provide supports for people with dementia. Everything from groups getting together just to go out for coffee and be in the community and hang out together and whatnot, to the Alzheimer's Society doing public education campaigns, to an art project that the Godfrey Dean Art Gallery did about living with dementia, done by people with dementia and their care partners. We have a film premiere next week. We're going to show it at College Avenue campus, an hour-long documentary about that project. And I think in the 25 years I've been doing this, no project has hit me, or the rest of the team, because everybody knows somebody who's had or has dementia, and the lack of services was just so incredible. And now we're coming to the end of this project, and we're working really hard with these groups to try to sustain these interventions, right? And that's always the problem, because the money from ESDC is gone, right? And it will end as of July. And so we're trying to figure out, how do you guys keep this going in an important way? Alzheimer's Society, that's relatively easy. They're a big national charity. They'll keep doing their public education. But some of the smaller groups were really struggling with that. So that's basically how I got into this. And, you know, as I said, it was entirely by accident. I had no intention of doing healthcare. And now I can't see how I would do anything else with the time and both of the research and the teaching.
Thanks for that, Tom. I think we'll maybe go to our next question, but again, if folks have thoughts, questions, things that you want to share, please just throw up your hand, we'll bring a mic out to you. Please feel very encouraged and supported in doing that. And maybe I'll go in reverse order, Tom. We talked about the research project that you've just done on the state of rural healthcare. Obviously, we're sitting in the south end of Regina. But our second question for the audience is what changes or investments do you believe are necessary to strengthen our province's public healthcare system? Because I'll be the first to admit, like, healthcare is not my file. The amount that I know about healthcare is largely through our constituency office, through working with people like Dallas, through advocacy, through things like that, and the bits and pieces that I get to learn as an MLA. But I think everyone knows the status quo is not great right now. so I know this is a big question. But Tom, you just published a large report. What,
Yeah.
you know, in a few minutes, what can you tell us?
In a few minutes, what can I tell you? My two co-panelists here sort of made reference to the fact that, you know, they don't mind speaking up and sometimes maybe getting themselves into a little trouble. I get myself into a little trouble in the same way sometimes. And here, let's start with this one. The system as we have it, in terms of the amount of money we spend, is not profoundly underfunded. How we spend that money is really screwed up. It's not really, in my mind, about massive new investments of new dollars. It is about spending money a hell of a lot smarter than we've been spending it for the last 35 years.
Can you give us a couple specific examples?
We continue to pay doctors on fee-for-service. And that's just not an efficient or an effective way to pay doctors. It drives up the cost and it actually incentivizes volume over quality. Right? It's piecework. So if you're piecework on a sewing machine and you can turn out 6 shirts in an hour and that person can only do 4, you're gonna make more money. If you can see 6 patients in an hour and the doctor beside you is only seeing 3 or 4, you're gonna make more. It incentivizes that. We've known this for decades. Health policy analysts have been screaming about fee-for-service since the 1940s. Quick story about the Rona Commission. Friend of mine, health policy guy in Ontario, I got my job, moving into my office, this envelope arrives. And it goes, and there's a letter from his Michael Becker in Ontario, and he sends it, and he goes, I found this in my files, thought the Rona Commission could use it. It was a mimeograph of a submission to one of the commission or the groups in the early 1940s that Douglas set up to talk about what Medicare should look like. And it had a list of chapter titles: primary care reform, ending fee-for-service. It was all of the things that, you know, we had a chapter on each of those things in the Romano report, because we've been doing this for so long. So, you know, I get really sort of frustrated about this. It's less about how much we spend and it's more about how we spend. And we need to move money to the front end of the system. We need to move it into prevention and the like. We need to move it into harm reduction and all of those sorts of things that stop people from getting sick. What we have is a sickness system. We don't have a healthcare system. We treat illness, we don't prevent illness. We need to rethink that. That's a hell of a lot harder to do than it is to say. And in part of that is because there are very powerful vested interests in the healthcare system who like the arrangements as they are, because it helps them. And I include all sorts of health professions in them, doctors and nurses and whatnot. They have vested interests in the current structure of the system. And so, you know, first and foremost, we have to move that. I think we have to start to shift our emphasis into that prevention and the like. Stop being quite so fascinated with the machines that go beep and the fancy new drugs and all of that, and spend much more time on stuff that's relatively cheap. It's relative. That's the cheap end of the system, right? And you could save such an incredible amount of money just if you could prevent people from getting ill in the first place.
But isn't that part of the culture? I mean, there was I saw this report from this Dr. Christensen, and he talked about the sources of, and he's a pediatrician, I think, and the sources where he talked about, I think accentuating sort of the First Nations situation, but he talked about violence, and he talked about the cyclical nature of homelessness and the very things you mentioned, and this culture of violence and not looking after yourself and dealing and all these other, and alcoholism and addiction, and you mentioned harm reduction, not putting money into that. And these are the sources, according to him, of many problems. And it's not, the healthcare system is a symptom. The problem, that's a symptom of a bigger problem, which is like this whole giant piece of situation you've got that are.
Much of the solution to what's wrong with the healthcare system actually lies outside the healthcare system.
That's right.
It's about investments in other things. Ted Marmer was a health policy guy in England. The British government at one point put out 10 ways to be healthy. And it was all the typical, don't smoke, eat right, get regular exercise. It was about participation is what it was. And Ted Marmer wrote back, the English strongly worded letter to the Times. This is what, and he went, I'll tell you how not to be healthy. Don't be poor. Don't have poor parents. Don't live in substandard housing. Don't, have a good, well-paid, unionized job. All of the, and he just went through the whole list. He goes, telling people in desperate situations that they need to eat their vegetables is not going to make people healthy. Curing the social ills that they are afflicted with will help make people healthy.
So how do you change that culture that we've known all our lives?
I have to agree on prevention. I know at the Cancer Society, so smoking is a great example, right? Public policy to help people, to help and make it easier for people to make healthy choices. So if you can't smoke in a public place, you will smoke less, and eventually you won't, it'll help you to quit, right? And I know when I was working, I think that at that point, before I left, I think the government was pulling in $147 million in tobacco taxes, and we could not get $1 million toward prevention to help people quit. $1 million, and you think like the return on investment is huge, right? Obesity is another issue, and I know it's not it's a complex issue, but the cancers and heart disease and diabetes associated with obesity are huge. I was listening to a podcast today, and this fellow, you're talking about Ozempic, this new weight loss drug, but yeah, they talked about Japan, what Japan is doing, and in Japan, I think the obesity rate in Japan is 4.7%. In Saskatchewan here, it's 38%. They are a wealthy country in the same way that Canada is a wealthy country, but there, for example, when kids go to school, starting at age 5, they walk to school. When they get to school, there's a dietitian on staff. Kids are not allowed to bring their own lunch. Lunch is prepared for them, healthy food. They're educated about that food and what that food does for their body. It goes on and on. So, prevention is huge. I know it's not easy, but it is an inexpensive thing to do. And we are a sick population, and I know it's hard for governments. Aleana, this isn't directed as you.
I'm in opposition.
Yeah,
I just
yeah,
get to
that's true. That's true. That's going to be different. But I think sometimes those aren't sort of the sexy ways the governments want to spend money, and they're thinking about sort of 4 years ahead. Is this going to get them elected? And I often say that I think as Tom mentioned, there seems to be enough money in the system. It isn't being spent appropriately. Our system has not changed with the times. It's still, virtually the same system that it was when Medicare was first established. And I think sometimes it might be worth sort of an arm's length group of experts, economists, healthcare professionals, social workers, educators, coming up with strategies rather than leaving it to government. because sometimes the best thing to do isn't the most popular thing to do with the public as well, right? I think, you know, the public is, you know, they have ideas of how things should work and where money should be spent. And so, you know, I think I agree with what you have said, and I think, but I do think a lot of it has to do with things that we could be doing at the top, that are really simple things to do that would require less help.
I'm just thinking back to when I was young, very young. I had to have my appendix out, and it was $200 for the operation, and my dad had to pay for it. That was in 1958. Is this on? Yes, you can hear me. At that time, the hospital was administered by an elected volunteer, people who were not paid, but they were an elected hospital board in a little town and the area. Now, there was no, these people received no money for what they did. And they may have been elected year after year after year, but there was no money changing hands. And what, like the volunteers in the community raised money for the hospital, for a new hospital, for paying the doctors, and then, of course, there was, if you could afford it, you had your own private health insurance. But if you didn't, you had to, if you went to the doctor, you had to pay for it. So, it was almost like, not too many people went on a regular basis. It was like going to the dentist only if you're toothache. But, it was, the cost of our health care back then was minimal. The hospital paid for itself pretty much. And I remember when the government decided to amalgamate some districts. There was a big town hall meeting like this, and there was people in tears because they were going to be losing their little hospital where people went if they needed help right away. And I'm talking about a farming community. A man gets his ring caught on a piece of metal and it could lose his finger. But there was a doctor there and a hospital that he could go to right away to take care of this instead of having to go to either Brandon or Winnipeg or Regina or wherever. There was a hospital there within a few miles. So when all this started happening and the districts were being drawn in, they weren't as big as they are now. And now I believe all of Saskatchewan is under one great big umbrella. Whereas when we first moved here, it was, the district was going north a little ways and maybe extending as far as Moosomin. And we're going, you know, home care people say, am I going to have to drive to Moosomin if I'm assigned a person out in Moosomin? And supervisors say, well, yeah. It was becoming, and this was a few years ago, 15 years ago, this was becoming a source of concern for the caregivers who were having to make that drive. And that was one way and then back again. And it might take their whole shift to go and look after one person who perhaps out in that area, there was a caregiver who could look after that person within 15 minutes or 10 minutes or whatever, but no, we take someone from Regina and drive all the way out there. Like, it wasn't making any sense at all. And that's where I say bigger is not necessarily better. Maybe part of what we have to do is start shrinking back and opening up our little hospitals that have been closed. And people are upset because they're losing their doctors and they're losing their care facilities. And maybe not open them all up like they were, but make the areas workable so that you're not having to make the big drive. And I'm thinking of people who are, like with transportation, There's no buses anymore, that our senior people can go to a hospital or see a doctor within 20 miles instead of having to make it like a 3 or 4 hour drive. So this is what my feeling is for a change in our money is being, as taxpayers, is being spent for healthcare. Maybe it needs to shrink back a bit instead of getting bigger and better. Yes, we need the big diagnostic stuff. I myself have been exposed to it as of yesterday. But for those times, we don't need to have it right where we are all the time for the few times that we need it. Now, if you needed a doctor, and I go to the doctor once every 3 months, be nice if I'm lucky, my oncologist is here in Regina, I live here, but somebody else, I have a friend who lives in Waverly and she has to drive in from there. Would it be nice to have an oncologist in Waverly or Estevan? Yes, it would. And why can't that be? Why can't the hospital there have doctors? Now,
This is a great segue.
okay, I'll just carry on. I'll shut up now.
Just a reminder to our panelists to hold the mic real close up to your mouth.
All right, I didn't want to be, getting that high squeak.
Oh, you won't get it.
Okay.
This is a great segue to our third question, which is about increasing patient access to healthcare. Because I kind of want to frame and kind of throw back what I've heard. Like Dallas, you talked about the importance of local voices and local autonomy and some of that expertise and access in a province like Saskatchewan. And Donna, you talked about the importance of prevention, and Tom, you talked about some of those bigger, crippling social, structural changes that we might need to make, and those really important public conversations around things like upstream investments and prevention as well. Healthcare is political.
Oh, yeah.
Right? And one of the things I hear, and I guess I want to check this as a bias, is a lot of what we see coming through the office is people who can't get the care that they need. And I don't disagree. I mean, I'm nobody, I'm not an expert in healthcare, but everything that you've said, all of you today, passes like a head nod test. But the immediate concern seems to be people getting healthcare. So yes, we should make these giant structural changes. And yes, I wish every single person in this province should have care where they need it, when they need it. How do you, I don't know who wants to jump on this. It's a big question. How do you increase patient access to healthcare?
Well, I'm going to just talk about my mom here.
I'm just going to talk about my mom, and so I'm from Kenora, just north of Yorkton, 30 minutes away from Yorkton, and my mom is 84 years old, and she drives to Yorkton to see the doctor because that's where the good doctor is. And when something happens to her health, when she's had a couple of situations, she called an ambulance to go to Yorkton, despite the fact that there is an emergency ward in Kenora because there's better health care in Yorkton. And I think, given how difficult it is to attract people to rural areas, that is just a fact that we have to accept, that you cannot have specialists and doctors and teams of healthcare, good healthcare providers in every community. And I was listening to an interview with Jane Philpott, who's a former federal health minister, in her new book. And she talked about primary health. Again, that is the most important thing. People don't have a doctor. 20% of Canadians don't have a family doctor. And quite often, by the time they get to a doctor, their situation, cancer, for example, right? Unless you are regularly screened, you could develop a cancer that is going to require a heck of a lot more money and attention and care than had you been screened. But people just don't have access to it. And so she talks about, and I think, this is something for Saskatchewan, given our sparsely populated province, primary care centers, where you have a team of a doctor, a nurse practitioner, a social worker, physiotherapist, a dietitian, what have you, in a center. And when you move into an area, you plug in your, this is her idea, you plug in your postal code and that's your care center. And sometimes it requires driving an hour, sadly, but that is just the reality here in Saskatchewan with our distances and our million people. And I think, it's to the point where people, they want a doctor. I mean, my doctor just retired. I was really fortunate that a good friend of ours talked to a physician here in town and he took us on. I'm really lucky because I've been looking for a while and calling some doctors, some young doctors I was trying to get in with, and they just weren't taking patients. And Jane Philpott said, it's like school. When you move to a new area and you need to register your kids in school, well, you call and there's a school in the area or wherever there is. That's where your kid's going to go to school. And that kind of, I think, with healthcare and the importance of primary care and getting your healthcare dealt with early, I think that's something we should do. And I don't understand why we aren't doing pilot projects, for example. Like, well, let's try 4 pilot projects, and maybe we are. Maybe I'm missing something here. We are doing that? Oh, good. Okay. Well, I'm going to pass it on to you.
A couple of things. Just first of all, Aleana, thank you. Thank you for framing this as access to healthcare and not access to a family doctor, because for many people, they don't actually really need a family doctor all that often. They need access to primary care services. They need someone to help manage their diabetes or their high blood pressure or all of that. And that doesn't need to be a doctor. That can be a nurse practitioner, that can be a physician assistant, that can be a really well-trained RN. There's all sorts of ways you can organize this. So it's about access to primary care services, not just doctors. Because when you frame it as doctors, then it's all about, we need to make more doctors and get them to go and live in Eston. And I got myself into trouble at the Association of Rural Municipalities conference one year when somebody said, how are we going to get a doctor in my town? And I looked them square in the eye and I said, you're not. Because they don't want to come to a town of 1,500 people. It's just the reality of the situation. So rather than reopen the old hospitals, I'd bring back STC. There's a healthcare investment. That to me would be a healthcare investment, because that would help alleviate the challenge of getting from one place to another for healthcare services. It doesn't alleviate all of it. You get into Saskatoon or Regina, you still have to get around the city and all that sort of stuff. But it would be a start to patching back together that network that was STC. I think is a huge, important thing. It's funny, you mentioned pilot projects. And you also mentioned Jane Philpott. I'm a huge Jane Philpott fanboy. Jane Philpott's new book is brilliant. If you haven't read it, go and read it. She was, I think, the best federal minister of health since Monique Béjean. And Monique Béjean once famously said, Canada is a nation of pilot projects. We have pilot projected every conceivable pilot project in healthcare that you can imagine. And we pilot project and we evaluate it, and then we close it down and we don't do anything with it. And we do this over and over again. And it used to drive Monique absolutely bad, because it was just this churn through the system. One of the things I would say, especially around the primary care teams, is we have to stop also looking for the model, a model of primary care team. The context in which you are trying to deliver the care will determine what you need in the team. Sometimes that team might be led by a doctor, and that would be appropriate. But it doesn't have to be led by a doctor. Don't let the Saskatchewan Medical Association know I just said that, because they will not be happy with it. But if you're in the downtown east side of Vancouver, your first point of contact for your primary care team probably doesn't need to be a doctor, it probably needs to be a medical social worker who can identify the combination of likely issues for someone who's living in the downtown east side of Vancouver. Can do, and it's like, okay, for this you're gonna see the doctor, but you need a mental health caseworker and you need this, right? And that would be a far more appropriate point of entry into primary care than just going to see a GP who is going to, because that's what they do, think of things in medical terms and only in medical terms. And that's fine if it's a medical problem. Not all the problems are medical problems in that way. You need other access points. And so, I think you really have to have a whole lot of flexibility in design. And I think that's really true for a province as rural as this. And you're right. We were talking about this before the session. This province is 30% rural. It's the most rural province in the country. But in 10 years, it'll be 25% rural. And in 20 years, it'll be 20% rural. And that's not gonna change. You can say all you want and do every campaign you think about the joys of living in a small rural community. And I'm sure there are many. It's not gonna change a worldwide trend since the Industrial Revolution towards urbanization. Rural Canada, rural America, rural Europe is all slowly melting away. And that's an unfortunate reality. What we have to do is provide the services we can for the people while they're there, but we also have to think ahead and think about these are services that eventually will be consolidated. And that is, I think, that's not a fun message, but I think it's the reality of the situation.
Isn't that where we are now?
Yes.
We're already consolidated as far as we can. Like, Saskatchewan is under one.
Well, in the governance, and one of the things that was really interesting about the report we did when you mentioned that one of the biggest complaints we heard from healthcare workers in rural Saskatchewan was the single health authority and what it had done to their job, because their manager now manages not a facility, they manage the food services in this facility, that facility, that facility, that facility, all over a large area. So they're not in any one facility all day. And so the people who work in providing food in those facilities don't know where their manager is because they're scattered all over. Whereas under an older model, there was a manager of the facility who looked after all the aspects of the facility. And that dividing up the job that way can work in Regina if you're the food service manager for 4 different facilities in Regina. Then you're just driving around one city in the day. You're driving 100 miles. It makes no sense, and there's the level of frustration and anger with this single health authority was, and it was really unique because normally what you hear when you talk to is a focus on Saskatchewan Health, on the health department. Is the first time we heard, wow, they recognize that it's the Saskatchewan Health Authority that's in charge and not doing its job. A large part of that we can also talk about politicizing the health authority and all those other things.
Yes, I just wanted to make a comment. When I was growing up in rural Saskatchewan, we had a local hospital. and we have local businesses which we patronize. Now the rural area I grew up in, there's no stores in either of the small towns close to me. My brother drives to Lloydminster rather than to the small town to pick up a gallon of milk. And so if these people are going that far for any service, why do they expect their medical services to be the same local hospital when they won't patronize their stores? There's no stores in those towns anymore, which creates a lot of difficulty for a lot of seniors who don't drive.
Yeah, that's why I'd bring back STC before I reopen any of the hospitals. I think STC would do more good for the health of people in this world.
It's interesting. This is our second town hall in as many months. The last one was on crowns and different ownership structures. I'm the SAS power critic, so I was really hoping to talk about like power generation and the environment. And boy, if we didn't spend like half the time talking about STC and transportation and profits, and talking about it as economic infrastructure, talking about this healthcare infrastructure.
I don't think a lot of people in the province recognized how integral STC was to the healthcare system in rural Saskatchewan.
You talked about these pilot projects. You talked about these pilot projects. Those are actually occurring as we speak. And where are they? And how are they?
We do pilot projects all the time. Like and one of my favorites. Again, the Ontario Medical Association hates it. They created four practices of nurse practitioners in rural Ontario, rural northern Ontario, in different towns. One doctor. The doctor works for the nurse practitioner. They only send him the cases that they can't deal with. That doctor only has to deal with the interesting, complicated stuff and doesn't have to, and the nurse practitioners do everything else. Pilot works wonderfully. But no.
In Saskatchewan, they're not doing anything here like that?
Not in that sense. But what's going on in Ontario is they're not expanding that pilot, even though we know it works. Because the Ontario Medical Association doesn't want it to be expanded. We have in BC, now, for once I will give this government credit for something. In BC, they have what are called full practice nurse practitioners, which is it's about almost 90% of a doctor in terms of skill set. Our new training for nurse practitioners in Saskatchewan is going to be aiming at producing full practice nurse practitioners. Now, if the Saskatchewan Medical Association actually steps back and lets them practice to the full scope of their training, we could do all sorts of things. But the SMA will, you'll hear it from them. Oh, you have to have a doctor in charge. If you don't have a doctor in charge, people are going to die. And, the Saskatchewan Union of Nurses, not that long, decade or so ago, was running ads. If we have too many LPNs, licensed practical nurses, in the system, especially if grandma will die, because every nurse should be a registered nurse, a 4-year baccalaureate in nursing, none of that, right? And it's health professions, turf protection, right? They're defending their turf. My profession doesn't. We're academics. You have to have a PhD, you have to do this, right? And if you don't, you're not one of us and you can't be in our guild. Every profession does. They don't like it when they get called out for doing it, but that's part of what I like to do. And those are the kinds of things that we need to break down and that the public has to get angry about and say, if you have a pilot that works, why isn't expanding. And we are notorious in this country for funding pilots. And then the report gets filed.
But it seems everyone's perpetuating this myth, if you will, about I need a doctor, and both governments are guilty of it.
Governments are guilty of it, the public is guilty of it, the media is guilty of it. It's the shorthand language, right? I need a doctor, because you've always gone to a doctor. You know, my father passed away about a decade or so ago. I don't think I could, my father didn't like the fact that his doctor was only 50. Right, he was way too young to be, you know, as far as he was concerned. I'm not sure whether we could have got Dad to a nurse practitioner. I'll go to a nurse practitioner. I could care less. My mom and Dad probably would not have gone, because when you're sick, you see a doctor, and that was just, you're not going to shake them from that. I think you can shake younger generations from that if you start putting these professions out there. We're still new to this in Saskatchewan.
So maybe in a strange way, the fact that people are struggling to find a family doctor, they will be forced to see a nurse practitioner or what have you, and that can...
And be delighted at the quality of care.
Exactly.
And anybody who's a member of the Regina Community Clinic probably knows you spend many of your appointments will be with a nurse practitioner or somebody other than a doctor, because you don't need to see the doctor to get your prescription for your blood pressure medication refilled. The nurse can do that just fine.
When you think of how long it took for the medical association to sort of allow pharmacists to prescribe, you know, certain medications, right? You've got a cold infection or UTI or what have you, right? And how long it took, and how much money it saves by just being able to go to your pharmacist and get the medication you need.
I think that's a really interesting point, and like, I've never heard it put that way. And you know, putting it into that perspective, I would personally be so much more comfortable seeing a nurse practitioner than a doctor. I'm diabetic, and so, you know, I have to go every 3 months and get my blood work and you know, kind of meet with my somewhat intimidating doctor, and you know, I have a little bit of white coat syndrome, so it's hard for me to get there. If I knew that was an option somehow, so you know, if that is in the community, it's not well known. So, you know.
We've only just started training. We've had licensure for nurse practitioners in Saskatchewan for a while, but we've only just started training our in the last few years.
But isn't there 300 or so odd nurse practitioners?
Yeah, but we had to bring them in. Like, now we can train our own.
Could I say something? First of all, I used to work with Donna and Dean at CDC. My name is Sean. Nobody knew me, but Donna and Dean were on TV. I was in the radio department. But working for the radio network, I did get an opportunity to work on historical documentaries of the front end of Medicare. And what was really interesting is, sort of moving about this meeting, is we created Medicare for Canada in rooms like this throughout Saskatchewan in the 40s, and 50s and 60s, in Regina, in Sturgis, in Kenora, and whatever. And those people were willing to confront the status quo of that time. And they were willing to oppose the Saskatchewan Medical Association and vested interest. The American Medical Association came into Saskatchewan. And what people did is they imagined what they needed. In those days, very different. Saskatchewan was 80% rural and about 20% urban. So we needed a very different mix of it. But I guess what I'm saying is if we recognize that we have the power, we can imagine a new system that is more reliant on things like nurse practitioners and primary care centers and all the rest of it. We just have to demand it and organize this. Because our parents' generation and our grandparents' generation organized and met that challenge. And just one other thing I think is interesting, it's a fairly famous anecdote. Tommy Douglas was asked in the early 1960s, what would the future be of Medicare? And he said that if you want it, each new generation is going to fight for it. And effectively, if you want a better system, you're going to have to be willing to organize and fight for it. And I think what they're good ideas here, and they have to be propagated and spread.
But at the same time that you're making these changes, you have to make sure that the scopes of protection, or the scopes of practice are changing. Because you can't have one without the other. Your example of the pharmacists. It wasn't so much the doctors saying, yes, we'll do it, it was the government approaching them between the pharmacists and the doctors and say, let's find a way to make this work for everybody. So the scopes of practice have to change before you can put all of that in place.
And just on the pharmacist question too, you also have to keep in mind, we separated prescribing drugs from selling drugs for a very good reason. You don't want the guy who's prescribing them to be profiting from what he's prescribing. And you don't want the guy who's filling the prescription to be able to be writing the prescription. Right? There's a conflict of interest there. And so we kept that line, and that line was very strict and very separate. That line's getting fuzzier now. We're allowing them to prescribe. We also have to watch and make sure that this is done ethically and all of that. This is a self-regulating profession, and we're going to respect pharmacists' right to self-regulate, but they better self-regulate. Because, when doctors started writing prescriptions for antibiotics like gumdrops, we started to make noise, and we said, you guys have got to stop this. You've got to stop ending every doctor's visit with a person with a sniffle by giving them antibiotics. It is not good for the system. It is expensive, and it's actually having longer-term health implications about the effectiveness of the antibiotics we have. And doctors have, to a large extent, changed their behavior because we demanded that they change their behavior, and the medical associations and whatnot backed us up on that. And that was important. And the colleges as well. And so the pharmacy thing is an interesting thing because they want to play a bigger role, but there are sort of regulatory and ethical issues that we always have to keep in the back of our mind about, okay, there's a reason why you're the guy who sells drugs and not the guy who prescribes drugs. So.
We've got another comment over here.
We were talking about coverage and about preventative care, and I think two of these significant things that are going on now in Canada. One is we're starting to get public dental care for seniors, and we're starting to get public pharmacare. And it's fascinating because one thing you hear people say is that, well, if the government provides those things, you're going to lose your workplace coverage. 20 years ago, I negotiated workplace coverage, and it's one of the very few things I actually got to thank you for. But that's a crappy way to do that. You know who organizes their system that way? The Americans organize their system that way, right? So that for a few people who are, can't afford it, that the government provides it, and other people get it through work, which is fine until you change job, or until you want to set up a business, right? Or until your plan doesn't cover you because you got some pre-existing condition. And that's the beauty of our system. It's insurance. And the way you get insurance is to have a big pool and have everybody contribute to it. So I think we need to push back very hard, right? That system of private care made Bill Morneau, the old finance minister, a very wealthy inheritance in the family business, but it's not good business for us.
I'll play devil's advocate for you for a moment. Here's the challenge, though, in convincing Canadians about your argument. What if what if my drug plan at work is really, really good and covers everything I need, and the one the government offers is not quite as good? because it's trying to be more cautious with the money, right? And that is the question you get from people, is like, I'll give up my work plan, my workplace drug plan, if you can guarantee me that that public plan is every bit as good. Now, the middle road on that is the Quebec model. The Quebec model says everybody has to have drug insurance. You can get it through work, and if you get a really good plan at work, that's great. Kudos, you get it. But if you have no plan, then you have to buy the public. You have to buy the public drug plan. It's essentially
Obama.
It's Obamacare. I'm going to say that out too loud. But for drug, and that's the Quebec model. It works in Quebec. It's more expensive than your model of a fully public model. I would love to have a fully public model. Again, the insurance industry is going to have something to say about that. And the Bill Morneaus of the world and whatnot. But, so that's, the compromise might be we end up with something like the Quebec model, which as an interim step, I'd still take over the current thing of 60% of people have drug insurance and 40% of people might or might not have drug insurance, depending on where they live and who old they are and what they do for a living. So,
Yeah, I think I saw another hand. Throw your hand up and Josh will bring you the mic.
What I wanted to, I just want to focus on something different, but it has to do with this whole thing. The last time that I was in Vancouver, about 10 years ago, I happened to have CBC on, and they were talking to somebody who is going to be doing a meeting with one of the political groups in Vancouver, and I didn't know whether it was the Conservatives or the NDP or who it was. But one of the comments that she made was that you have to be really careful when it comes to developing these kinds of initiatives in terms of electing officials. She said, you go to a meeting where there's a whole raft of people that are wanting to be nominated for, it could be a position like in the party. They have a chance each to speak. And what happens is that you end up choosing the person who has the best gift of the gab. It doesn't mean that they know anything. It just means that they know how to talk. And this is the thing that bothers me, is that I think a lot of these issues are left to the politicians to try and resolve. And then the media gets hold of this, and all they're interested in is looking at who's fighting with who and who's name-calling the best. So that the net result is that the average person out in the community that's dealing with addictions or with healthcare issues of all kinds, their needs are not looked after because it just becomes a political game in the House. And I don't know what to do about that.
So yeah, I don't disagree. I mean, part of politics is who has the best gift of the gab, but an important part of, at least what I believe, how democracy should be functioning, and I think an incredibly proud part of Saskatchewan's history was having a professional, nonpartisan civil service, which used to be, I believe, the best in the country. And there are remarkable people doing the Lord's work right now in the civil service with little thanks and little respect. But what I see, what I hear from people who have recently left the civil service or been left by the civil service is, and it was mentioned here today, an increasing politicization of what should be good. I'm a New Democrat, I love evidence-based policy, but good evidence-based, pragmatic, value-focused delivery of public services for the people of the province, and we don't have that right now. I don't want this to just turn into a barn burner from me on
we
the
came
many
for-
failings the many failings of the government. But I'll give you a couple examples specific to healthcare. To your point, which is not going to make you happy, and is probably just going to lean into what you were, the other evil you were talking about in terms of like pointing out all the failures of the other guys, which I'm pleased to do. We talked about the SHA, we talked about the centralization of the health authority into one. The Board of eHealth Saskatchewan right now is made up of, I believe, the deputy minister and the assistant deputy minister. That's not good governance by any stretch of imagination, and that is not leading to efficient business or service delivery for the people of the province. And that is a clear example, I think, of a failure of governance, and it's a very boring example of politicization of what should be public service delivery in Saskatchewan. Another terrible example is one that there was somebody here tonight who stopped in but wasn't able to stay because they were feeling ill, around harm reduction. And I don't know how closely folks have been following some of the changing narrative out of this government when it comes to addiction and mental health. And anybody who has walked down a street in Regina right now knows that things aren't good out in the community, and can see the visible impact of addiction and poverty in our communities. My daughter's 3 years old. I take her to daycare at the YW downtown. Wonderful facility, and we have gone from seeing people in a bad way to people openly using intravenous drugs to, a couple weeks ago, we saw somebody overdosing at like 3 in the afternoon when I was picking her up. It's not good out there. And this government is choosing to reduce access to, they're gonna say, the NDP wants to legalize drugs and give everybody, like meth and things like that. That is not the case. We want people to have access to treatment when they need it, because we know that isn't accessible. But this is a government that is limiting access to things like clean needles. And the reports that we're having out of health facilities in the city right now is, it is so desperate that the Sharps disposal boxes that you'll all, see in washrooms, those are being stolen right now, because people who are addicts do not have access to clean needles, and we're already the province that leads in HIV infection rates. So we want to talk about prevention.
Yeah.
I want to talk about political, ideological decision-making in things that should not be informed by ideology. There are real costs to this, and you're right, I think it's directly related to the way that democracy isn't functioning right now in Saskatchewan, and the politicization of the civil service. I don't know if anybody has any less aggressive examples that they want to share, but amen, brother.
Really ironic because Saskatchewan had the first non-partisan political service established in the 1950s by Tommy Douglas. He hired a deputy minister named Al Johnson from Donna, Saskatchewan, to create it. And Johnson was so effective in doing that, he was hired by Pierre Elliott Trudeau in 1968 to reform the federal civil service. So we led the nation in Medicare at one time, and we led the nation in having a clean, nonpartisan civil service. So we've come a long way back from 1954.
And the other half of that was Tommy Schramm.
Yes.
And that is why that public policy school is named after those two
That's
men.
right. And you know
It was
how
Al
Shoyama-
Johnson and Tommy Schramm that created our public service.
And you know the story of the Shoyama's guy to Saskatchewan? Have you heard that one?
No.
He and his family were Japanese internees by the Canadian
course.
government.
Yeah.
And at the end of the war, all their property, I think the Shoyamas were either from Alberta or BC, they lost everything. And so Tommy Douglas said to the Japanese population of Canada, who were dispossessed this way, come to Saskatchewan. And the Shoyamas come to Saskatchewan, we want you. And so it became a dynasty. There were multiple generations. The Shoyamas who played key service thanks to that invitation in 1940.
Just one thing I wanted to say though is about, and again, don't quote me on this, but I'm actually going to defend politicians, because I actually like politicians. I like most politicians. You're fine. We can't take politicians out of the process. Democratic governance depends on effective elected representatives. And so, yes, it would be easier to hand this over to a group of people and say, you fix it and we'll just let you do what you want and we'll listen to you because we're the public and we're easily misled and all of that. That's a denial, A, of our own agency and of the people like Dallas here and whatnot who speak up and are activists. It's our own agency as citizens. But it's also a denial of, that's their bloody job. It's from that legislature to legislate and to govern. And so, yeah, they're frustrating, and yes, they spend too much time yelling at each other, and yes, you never want your children to see question period, because it is not the best impression of how democracy works. But I want to fix that politics rather than abandon it.
Choose the right politicians.
Yes.
Exactly, exactly.
Go for it, Dallas.
It was at one of the town halls. It's on. Oh, it is on, okay. That someone mentioned that we've got some of the people who are in charge of the government right now, because we weren't paying attention when we should have been, and they were running for election, and we just sort of let them get elected, and then we're wondering, oh my goodness, we don't like what they're doing, but we like Aleana. But this is what kind of startled me, was that I don't want to use the word stuck with who we've got now, but it was because we weren't paying attention. So now we're sitting up and we're taking notice, and this is our time to have a change. And we'll talk to people like Aleana and the members of the opposition and let them know how we feel, maybe not what is going to be realistic to facilitate a change, but at least we're paying attention and we're participating in the elective process. And in the end, we'll be looking after our vulnerable people. This is what I realized when I worked on the Alzheimer's floor, that they were totally vulnerable, a vulnerable population. They didn't know their soul was their own lots of times, a lot of them, most of them. It was humbling, I guess, to see that I had a patient, a resident, who was a street person, but he was sitting in his wheelchair, sitting beside at one time, a well-respected physician in the community. And the two of them were on the same wavelength and carrying on. It is a very, very leveling disease. And people that vulnerable need to be protected. And we have people walking around that are vulnerable and need protecting. And I'm talking about the addicts out there, the alcoholics, the homeless, the people who, even if they do have a place to go and live, don't know how to look after that home because they've never had that experience of having a home. When we lived in Thompson years and years ago, I was friends with a woman who was a home economist, and her job at that time was to meet with the ladies who came in from the reserves and teach them how to use an oven how to clean their bathroom, how to use an iron, if a food processor, a microwave, a washing machine, how to just generally look after themselves and their families, because out there's no facilities, there's nothing. And then they're brought in, they move into the city and are expected to know all this that you and I grow up with. We see our parents doing it and they're expected to help, but these people do not. And there's where the vulnerable people need to be looked after. And not necessarily, well, maybe not looked after, but shown how to cope with living. And that's part of healthcare too. That falls into under mental health. And if they sort of fall down and they resort to drugs and alcohol and family abuse and all of the above, it's just a case of our society not looking after our most vulnerable.
I just want to follow up. I just want to follow up on something Dallas said about, we know now, right? We've heard some really great ideas tonight. Your insight and knowledge is incredible. And so, homework for you all. You share what you learned with a half a dozen of your friends. You talk about the ideas that came out of this. That's the first step. That's the first thing you do, is you educate your friends about some of the ideas and what's going on. Some of the things Sean talked about, way back when Medicare was established, rooms like this, that's what created change. So I hope you'll all do that. And thanks for being here. But I'm not wrapping it up by any means, but that's kind of...
I think we maybe saw one more. I think we've got time for one more, and then we should wrap it up. Cool.
I think another element has to do with people having a financial ability to manage their own lives. The poor and the working poor, when they're relying on the social service rates, there is no way that I could live on that. And how are they to provide rent, food, clothing, and the other necessities of living? I've raised Cain with federally and provincially the matter of looking at a guaranteed basic income for all Canadians. Then people would have the finances to look after their own needs, rather than us putting them in a position where they have to depend on us to be kindly and give a 3% increase in the social service rates, for this budget year. Those kinds of things that are insults when it comes to people that are struggling. What would you guys do about that?
When I was at Queens, there's a guy who lived had an office down the hall from mine by the name of Hugh Siegel, who some of you may know. Former fixer for Brian Mulroney, the happy warrior of the Progressive Conservative Party. Hugh and I, we got to be friends before he passed away. I really enjoyed his company. Hugh and I agreed on very little politically, except one thing. Hugh spent the last 20 years of his life in the Canadian Senate pushing for a guaranteed annual income. And that was one thing that actually unites conservatives and people on the left, is the idea that, heaven forfend, if you give poor people money, guess what? They'll spend it on food and shelter like everybody else. And it's actually teaches them all sorts of things that are, in fact, welfare system infantilizes people by taking away their control over their lives. And a guaranteed, one of the best things I've always supported something like guaranteed annual income is because it demands that you act like a citizen and you take care. We're going to support you, but you're actually going to run your life, and we're going to let you run your life. And yeah, sometimes you might make some bad decisions. Everybody does. I was a graduate student once. I made lots of them. You know, you get over it. But it, you know, I've always been a huge, you know, again, that to my mind would do so much on the health front, right? If something, you know, if we started with a guaranteed annual income, I have no illusions about how tough it would be. But again, you want to talk about pilot projects? Dolphin, Manitoba. They did a full-fledged, in the 1970s, we did a full-fledged guaranteed annual income program. All the evaluation was done, it works, and we shut it down, and we buried it until one economist at the University of Manitoba dug out all of the documents and began to go through the evaluations and publish a whole series of articles about the Dauphin experiments. And people went, oh, wow, this is very interesting. The one funny thing, there was one group of, you know, you can make people will quit their jobs and they'll just sit and live on their guaranteed annual income. There was one group who quit their jobs. 19 to about 25 quit their jobs because they went to school. They went to university. Of course they quit their jobs because they could actually afford to go to university and be full-time students like you're supposed to be when you're 19, right, at any university. You know, my university, I teach mostly second and third year classes now. My students are working 35 hours a week to pay for their education. None of my students are taking 5 classes. A, they can't afford it, and B, they don't have time because they have to work 35 hours a week to pay for the 3 classes they're doing.
So why did the Dolphin program stop?
Because the government shut it down. It was a pilot. The pilot ran its course, and they shut it down, and they never actually did the actual evaluation. It wasn't until the economist dug up the documentation out of the archives, and she started to run the numbers, and she discovered this was working. This was actually, and you know, she eventually did a whole book on the Dauphin experiments. It was fascinating stuff. And we did this in the early 1970s. You know, this is when Milton Friedman and the people on the left were both talking about guaranteed annual incomes, right? And we thought, well, this is an interesting social experiment. We did it, it worked, and so we put it on the shelf.
And then we've got one last question here.
It's not really a question, but a comment. I think that we can't talk about healthcare unless we're talking about the legacy of residential schools and intergenerational trauma. And I think some of the comments are skirting pretty close to not addressing those issues, and it's like people just don't understand because they haven't seen it. The reason they don't understand it or haven't seen it is because they were dragged from their homes and put into schools and abused for decades and generations. And I think that until we deal with that, our healthcare system is going to struggle.
Oh. Yeah, I just had a student of mine finish a PhD dissertation on the creation of the All Nations Healing Hospital in Fort Capel, which is a fascinating story because it's a tripartite experiment, pilot project, between the tribal councils, the province, and the federal government. And it is a provincially funded hospital that exists on a First Nations reserve. Never been done before. I was in SaskHealth when they were first talking about it. This is why he wrote the dissertation he did, is because I had this story in the back of my head. I said, somebody needs to tell this story. And there were fights in the government about, we can't do this. It's on a free, can't build a hospital on a reserve. To which a bunch of people sat around the table, including the tribal councils, and said, don't tell anybody, but if we all agree to do it, we can do it. If we all let each other do it. And it is, and it's not a huge act of reconciliation in my view, but it's a step towards the kind of stuff that we're actually taking, for the first time, I think the system is beginning to take seriously the Indigenous experience, and not just in this province, but across provinces with residential schools and the like. We have a long, long way to go on this. We're finally approaching, the health of Indigenous peoples. When I learned population health, it was just a series of statistics, right, about the age, life expectancy was lower and the substance abuse, and that's all you got was this sort of deluge of negative statistics. And you didn't get the story of the resilience and the strength it took to survive that experience, and what it's taking to overcome that intergenerational the trauma. And I think we're finally approaching Indigenous health in a way that is a much more positive sort of way of looking at it and seeing the potential that's there in the province. And let's face it, this is the one segment of the Saskatchewan population that is growing. It's growing and it's getting younger. The future of this province is Indigenous, and if we don't come to grips with that in some serious way, it's gonna hit us hard. But yeah, it's getting younger, and it's growing, and so those are going to be the people to whom the future of the province is. And so you're absolutely right. These are the kinds of things that we need to sort of confront and sort of bring on board in a much. I think we've made some start and we've made some progress, but there's a lot of work to do.
Sorry, I don't want to cut it off, but we did say we were done at 8, and it's almost 8:15. Sorry. Thank you. I know. Go figure. So thank you, everyone, for coming out tonight. Thank you for listening. Thank you for Gary. Okay.
Well, I just want to thank you, Aleana, for arranging this, and thank you, Aleana, for arranging this. And I want you to keep getting under Jeremy Harrison's skin.
I promise that wasn't a plan. Thank you all for coming out. Thank you to our wonderful community participants. Thanks Tom, thanks Donna, thanks Dallas for being here, for sharing all your experiences, your expertise. Thank you everybody for the great questions and for engaging. If you have any feedback, please fill out the survey, let us know. Please talk to your neighbors, tell your friends, and hopefully we'll see you at the next one. Thank you again.